So I would like to push the panel a little bit, given some themes that I heard pop out of both the keynote session as well as this panel. And I want to start high and then get us down to more granular. And at the highest level, I think one theme we have heard, not always explicitly articulated, is that there is a level of commitment that's required here. There's a level of commitment to a common and as importantly, sort of a mindset of collective prioritization, collective planning, and collective investment. So let me just ask the economist in the room. Your model is one approach, Len, but even your model requires that initial cultural commitment upfront within a given community. How do we scale that? What does that look like in the US?
Oh, great question, Mai. And the way I would say it quickly is everything moves at the speed of trust. And you remember when Don talked about the entity in Cleveland that's playing the key trusted broker role up there, which makes all these players come together and figure out what to do and express their collective vision. That united way is a very important part of this conversation. The good news is there's a creature like that in lots of places. And some places it's other united ways, and some places it's not. It's HIEs in some places, it's employer groups in some places, it's, God's blessed 501c3 in some places. They're all over. And the thing is, I would observe that the opioid crisis helped create an opportunity here. Because the opioid crisis, think about it for just a minute, sort of, metaphorically, you've got an emergency room doc, law enforcement, family services looking at the same patient, maybe recovering from the overdose. Then they say, what are we going to do about this problem? Well, there's a spouse, there's a neighborhood, there's a family. Suddenly you got multiple sectors looking upstream simultaneously. They don't have to go in a room and sing Kumbaya. They're all trying to solve the same problem. They just have to admit it to each other, Mike. And that's where your convening local trusted broker can play. And I would just say the opioid crisis was, you might have noticed this, everywhere. So these conversations took place in way more places than I dreamed was possible. And so I think there's a lot more opportunity to tap into that trust than we might think.
So I think that's fair. But then let's assume that we have trust and kind of a collective will. We actually do need to talk about where the money comes from, right? And I think I want to challenge you all, each in turn, to brainstorm a little bit here about not just who can bring the money, but from which particular pots. And there are pots of, it would be great if you could draw the distinction between new monies, that is monies that don't typically flow through healthcare, but that could be used to solve this problem, as well as repurposed funds. Where would those potentially come from? Tim Ferriss mentioned one source that we don't typically think of, which is those frictional costs, the administrative costs that drive through much of the sort of wasted activity in healthcare as one potential source. So Don, let me start with you. In your dreams, what are all the various pots of potential investment capital coming from?
I want to answer that question, but I don't. I have such better visibility right now because we're so in the thick of it, of the problems that we currently have. So maybe I can spend a minute on that and then take us to the, potential solutions. But I think we see over and over again that the kinds of changes we're talking about really require capital. And to your point, I think it takes resources even for providers to do things like change workflows or hire community health workers. It certainly takes resources to build these partnerships with community-based organizations. We know that it's challenging for safety net providers who are already operating on really thin margins to jump into value-based care. And it's not just challenging for safety net providers, it's challenging for most health systems. And there are some bright spots, but there are also areas of concern. And I think we're hearing a lot about those concerns right now around kind of a level playing field in value-based care, and the sense that well-capitalized Medicare Advantage organizations are much better able to manage some of these things we're talking about than health systems. as well as concerns about the role of private equity and consolidation. And so I think it's almost, we have a number of places where CMS has tried to create new mechanisms to engage in the kinds of whole person care and population health that we're talking about right now. A great example is the diabetes prevention program, where we thought, okay, we're creating a new sustainability mechanism for community-based organizations. They're going to be able to bill Medicare for these evidence-based services that they're providing that generate cost savings, but so many could not get over the hump of even like getting the billing systems in place. And so I'm afraid that, like so many things from a federal perspective, this is going to boomerang right back around to the things that we should be doing differently. I appreciate Len's recommendation around, looking at opportunities for braiding and blending, and thinking about, for some of the grants, for example, that are already going out the door from federal agencies, is there a way that we could target them to some of these issues to help organizations, get ready to do this kind of work or form those partnerships? The Administration for Community Living has certainly been working on this quite actively.
Well, not to interrupt your flow, Don, but I will just point out that President Biden has proposed an investment of $400 billion in home community-based services. And one question for you and for Ben is, how would you like to see that spent for us to develop this collective infrastructure?
And I think for my personal answer, I'm going to say that this is not the CMS answer explicitly, but my personal answer would be that we need to make really substantive investments in community-based organizations and behavioral health organizations that did not receive money under ARA and don't have some of the basic building blocks of, for example, the data systems that would allow them to effectively engage in these partnerships, as well as to really bring evidence so that those home and community-based services are not just custodial services, which is so much of what they are today, but are actually about bringing them into value, because there's a tremendous opportunity to have them support the goals that we're talking about here, but it won't happen unless it's very explicit.
Can I comment, and I just want to commend you, Dawn.
Absolutely.
That was incredibly brave for someone who works for CMS. And I thought, oh my God, does she know what she's doing to this poor government employee? So that was a great answer.
She does.
And I just want to say, and I'm a government employee too, but what the hell? Massive federal infusion of money into the healthcare system is the only thing that's going to fix it. Period. End of story. And we have to continue the will that's mounting now. And this is not the position of the VHA. This is just me talking. But the will that's out there now to really invest massively in our healthcare infrastructure, not in our health systems, but in our health infrastructure, not even our healthcare infrastructure, our health infrastructure. So we have to build on that, we have to leverage it, and we have to keep that strong and not let it be rolled back, because what we need is a whole different kind of infrastructure to promote health. The only infrastructure we have is to treat disease. We do not have an infrastructure to promote health. The infrastructure to promote health should not be delivered through the healthcare systems or through the typical healthcare payers. It has to go to the community. So one of the big dreams we have in VA is around this whole idea of whole health partners, who could also be called community health workers. And if you could fund a huge scale deployment of community-based health workers, not healthcare workers, who could be out there reaching out into communities, identifying people that need, helping with social services, delivered through nonprofit kind of umbrella organizations. I mean, that's a way to change what we're doing. That's the way to change what we're doing. If we're gonna change what we're trying to get, so we've been trying to shift to paying for value, and that's critical. Okay, we have to pay our healthcare systems for value. There's no way out of that. But we have to do something much more radical than that. We have to get responsibility for health and well-being out of the hands of the healthcare system and into the hands of the community and the people. And I know that sounds like pie in the sky, but that's the only thing that's going to work.
And just
But
to
we were
riff on
at-
why that's so essential, really briefly, I think none of us want to reproduce so we have to do that without over medicalizing, but none of us want to reproduce the high costs that are in the healthcare system. And it is so hard when we're implementing these things in a healthcare system to not get caught in an incredible focus on program integrity. And we see this with some of the social determinants work that's happening right now, where it's like, okay, we're going to help pay for your housing, but you're a Medicaid beneficiary who's living with a non-Medicaid beneficiary. And so we can pay like some portion of your rent for some number of months.
Yeah.
And our concerns about that can only be unlocked in all likelihood by moving it somewhere else.
Right. So I'm hearing certainly that federal government has a role, and I'm hearing that there may be some existing fund flows that we have at our disposal. Len, again, as the economist in the room, can I push you a little bit to riff on what about all the other dollars flowing through healthcare currently, right? There are tens of billions of dollars being poured, for example, through venture capital and private equity into new healthcare ventures. What is the opportunity there? Where do you see other potential sources of capital?
So great question. And let me just, if I could, go back to something that I think I said, be careful what you pay for. We're paying people to do stuff for which they get paid. We're not paying people to produce health. Private equity is buying up physician practices because they figured out coding and pricing, period, end of quote. There's a way to fix that. We all know a way to fix it, but it requires giving Dawn and her allies a hell of a lot more power than they have right now. But there's no other way to solve this problem. You're going to have to regulate prices that are too high. And, I'm not a government employee. I can say this in public. That's the only way to solve this short-run problem of directing incentives the way it should be. And I'll just point out, I know a hospital system, Bon Secours, at least in Baltimore, they put a community health indicator in the compensation function of the CEO. Think about that. If CMS were allowed, with Congress's help, allowed to require that kind of stuff in the incentive and compensation packages, I guarantee you stuff would change quickly. I promise you it's doing so in Baltimore. At the end of the day, you got to pay for what you want. And we have to define what we want precisely, as Ben just said, but you've got to put the teeth in those payment algorithms, and Dawn knows where to put them. She just needs the power to do it. I don't think it's rocket science. It really is about being clear, and it's really about keeping that North Star, like Mandy kept saying. What is the North Star? Okay, are we paying for the North Star, or are we paying for some damn constellation? And right now we're paying for the constellation, not the North Star.
And I just to clarify for those who may not know the entire sordid history of payment policy in Medicare and Medicaid, I think what Len's referring to there is the opportunity to not only pay explicitly for what we value, but to stop paying for other things that don't align with those priorities. And the fiscal opportunity there is tremendous. Probably way more than the 500 billions in frictional costs over time.
Yeah, although I would go get that. But I would just pick up on Ben's point. Yes, a federal infusion of capital for infrastructure would be a very nice thing. But there's a heck of a lot of sources of money out there that are outside healthcare. In Cleveland, my favorite place now, because they went first with my model. I love them, they're brilliant. But in Cleveland, when we visited them in February, they were this close as a community to erasing chronic homelessness in their county. And they do it because somehow they have enough, I guess you could say, nice apartment building opportunities that the builders of those apartments get the tax credits, and then they turn around and put some of that money into new public housing. They've made great progress in taking money from one part and giving it to another and creating what I would call a genuine health asset. And I think there's a heck of a lot more of that opportunity out there than we have tapped. And that's what I meant by it. Get O&B on the case. Make them talk about where money can be flowing back and forth. And if they can't make it flow like it should flow, have them tell us why, and we can fix all of this in one term.
It sounds like what you're calling for is a very systematic inventory of all the potential resources, and then some hierarchy of, low-hanging fruit, slightly harder, maybe impossible, but somewhere in the first two categories, we're likely to get more than enough of what we need.
At a minimum, a hell of a lot more than we think. Absolutely.
Yes.
Absolutely.
Well, Ben, I would love to toss you a question, because you have this on-the-ground experience with a system that was fairly centrally designed, but executed at a local level, and in many ways, almost an ideal crucible for seeing all of these different levers play out. Can you help draw out for us what you think in the VA experience is really generalizable, with not dramatic tweaks to other settings and contexts?
I think the most important thing that ultimately, and this is going to sound again kind of pie in the sky and idealistic, but it's this central concept that we're pushing out of the person being absolutely in charge of their own healthcare, and that the role of the healthcare system is to empower the person to have the conversation about what's important to that person, and then to build out that conversation into what kind of skills or assistance or tools do you need to move yourself towards what's important to you. So, the disease management part, we got it down, VA's got it down, we've got great outcomes, our healthcare system, great outcomes. Of course, we're going to continue that. But I think the real shift that has the potential to be scaled across every part of the American healthcare system is this idea of put the patient in charge, ask them what's important to them, ask them what they want out of their interactions with the healthcare system. Now, not everybody's ready for that. Not every patient, people are like, what do you mean? You're the doctor, tell me what to do, right? So, but at the same time, I think that's the shift. And I think the other part of the shift that's really scalable without massive new costs is going to be health coaching to really work with people around behavior change. And then the sort of grassroots community level sort of peer-to-peer health worker kind of work that I think is also not expensive and very scalable. And I think that's what we have that's catching on, that's really getting amazing feedback from veteran patients. And then the other parts of the system, it's great to offer acupuncture. I think that's really important. And that carries some of the same challenges as offering other services, quote unquote. But this idea of peer-to-peer work, health coaches who are very inexpensive, and putting people in charge, and then ultimately measuring outcomes that are patient-reported outcomes that reflect on, are people getting what they want out of their lives, and then looking back and seeing which of the interventions really helped you get there. So that's what I think we're pushing for, and we'll let you know how it goes. So far, so good.
I really feel like we've kind of come full circle. So I'd like Dawn and Len to just take a minute each to help close us out by acknowledging that Ben has taken us back to where we started, which was about culture and about the lack of the natural reflex in both government and the clinical world to assume that you should start with what people say is important, rather than, even if we have to go through a centralized planning and prioritization process, that's where it has to begin. So can you just close us out with your thoughts on just, what will it take to move us to that kind of cultural reflex? For example, Dawn, I don't think most CMS metrics are based on what patients consider important.
No, and I found myself thinking that throughout this conversation. Mai, you just said that so beautifully. And Ben, I'm like, I want to know how you're doing all the stuff you just talked about. So it feels a little bit technocratic, but that is what I am. So maybe I'll close there, but to then focus on this issue of, how we measure what matters. And we have sometimes a fear of the subjective. We measure patient experience, but like there is this element in which we almost don't trust patients. We also worry that what patients want, when we start talking about patient-centered, folks get very nervous about, are we just going to give patients everything that they want? And is that going to drive up costs? And do patients know what's in their best interest? And all this set of questions. And so I think we really need support from folks that are doing this every day. We actually had Sarah Santon present at CMS Grand Rounds yesterday, talking about some of her work on this, which was also incredibly informative. But I think we, these are huge challenges. And then the other piece that adds to them is this issue of how we think about social risk in this context. It's great to say we want to tie payments to outcomes and pay more for the systems that are producing the best outcomes, but making sure that we are also not, kind of undercutting or penalizing systems that really need resources to be able to generate those outcomes. So these are all issues that I think we're really actively working through and would welcome feedback from this group and others.
Len, close us out with what happens at a community level. How do you make sure the end users are up front and center?
So great question, Mai, and I would go back simply to what I've observed, and that is when the trusted broker convenes the stakeholders and they start thinking about, okay, what is the priority upstream? And the top 5 are the same everywhere, but they have different rank orders in different communities. And they look upstream and they say, okay, how are we going to solve this problem? And yeah, people like us can bring the literature and all the other examples and all the technocratic stuff. But at the end of the day, what matters is what the people upstream think about. And they all know this. And this is what's so beautiful about getting healthcare and CBOs together. You really infuse healthcare with that local knowledge, which is essential to getting past square one. And so I think it has to do with incentivize healthcare to value-base its payment and by God deliver results, and they will go upstream and figure out they better listen to the people who are on the ground and not going to solve their problem. That's all it takes. That's a lot.
Well,
That's all.
It's a lot. With that, thank you so much to Dawn and Len and Ben for helping to kick us off here.